Right, so today, of course, we had a number of different speakers coming by. Topic of discussion was the GI malignancy space, and I discussed specifically the colorectal cancer group of diseases. The major key take-home points, actually a few things that typically we don't see in these kind of meetings. We get updates. Many times the updates are things that are not really applicable right now, but are applicable a few years from now because they're very innovative, very cutting edge, and they do not become available right now. But we have a few updates that we can do meaningful changes to patient care right now. So one of them is the IDEA collaboration, which is basically an update from the data that we presented at this same meeting last year, in this case for high-risk stage 2 colon cancer. The question here was either is 6 months versus 3 months of adjuvant treatment in high-risk stage 2 colon cancer made a difference in outcomes. What we saw as part of the whole analysis of these many patients that were put together on the clinical trial is that if we're going to use a strategy of chemotherapy for a certain period of time, if we're going to use 3 months of treatment, we should use capecitabine-based chemotherapy. So the combination of capecitabine and oxaliplatin, it's favored to be used whenever we're going to use 3 months of treatment compared to 6 months. And we need to continue doing patient selection for these patients. The other interesting update was the update from the NRG study 002, where the cooperative group study that put together a bunch of rectal cancer patients and saw if TNT or total neoadjuvant therapy made an impact on the outcomes of patients. They also added on a PARP inhibitor called belimumab as part of the chemoradiation phase. They saw belimumab not necessarily improve outcomes, but we saw with the NRG study that it's very feasible in a cooperative group getting patients total neoadjuvant treatment for rectal cancer. That means that the patient gets all the treatment, chemoradiation followed by chemotherapy, a completion total of the whole regimen before surgery. And not only that's feasible, but we can potentially give those patients options to the whole treatment they're supposed to get before surgery, and after surgery they can enter surveillance knowing that they get all the treatment that they're supposed to get. And the one other update that I thought was very important is the updates from the TRIBE2 study. It was a phase 3 clinical trial, an update for the TRIBE study for colon cancer patients, looking for a triplet of FOLFOXIRI bevacizumab followed by maintenance. And if it made sense to either at the time of progression reintroducing FOLFOXIRI bevacizumab or do a sequential approach instead, where we did FOLFOX bevacizumab first followed by maintenance, and upon progression we just switched the patients to FOLFIRI bevacizumab. Many times we are concerned about using all of our weapons at the same time and instead of doing a sequential approach. So as of now, we didn't have any data, and this really gave us new information. What we learned from the TRIBE2 study is that using FOLFOXIRI bevacizumab and reintroducing at time of progression not only improve response rates, as we know already because we're using a triplet of chemotherapy, but we also improve in outcomes. So there's increased progression-free survival and improve overall survival for all patients. So now that changed the standard of care for many patients who are fit enough to receive the combination of 3 drugs plus bevacizumab, and it shows it's safe, and it's ideal for patients with right-sided colon cancer who have a BRAF or a RAS mutation and they're fit and able to get the treatment. So I think this is a very interesting update that we got from ASCO. And lastly, we show some data from the Foxtrot clinical trial and from the Rego-Nivo. More to follow on that, but those are the key take-home points that I took from this update. So thank you so much.